Hi, my name is Victoria Bird, and it's an honor to be a speaker in your summit. We're going to talk about quantitative MRI reading applications in prostate cancer. I want to start by mentioning that there's many FDA-approved and developing software for prostate MRI imaging, and the recent study showed that the AI system was superior to radiologists using the PIRATS version 2.1 on average at detecting clinically significant prostate cancer. This is an example of two of many different software available. I also want to mention that I'm a full-time urologic surgeon in practice with a large volume of prostate cancer patients. And I have two challenges. One of them is not only the ferrous materials that are intercorporeal, like hip prosthesis and uroliths that can obscure diffusion-weighted image, ADC mapping, and dynamic contact enhancement series, but also the variability of reading among radiologists of MRIs. I, for example, had one reading of PIRAS 1 and had Gleason 7 cancer, and then another patient with PIRAS 2 that had Gleason 8 cancer. And this is because I actually look for lesions, try to do my own PIRAS reading. Now, through the years now, I have use ADC values that has helped me identify more readily lesions in the prostate that correlate to cancer. Restriction spectrum imaging is a new modality that is being developed as well. So with that, I want to mention my goals. One of them is to identify cancer lesions in MRI and correlate to Gleason score. This allows me for early identification of tumors and improved detection with early minimal invasive intervention. It allows also to improve surveillance in a non-invasive modality. Also, second goal is to identify prostate MRI without cancer to prevent unnecessary biopsies, and also to identify extracapsular extension and to further stratify patients for high risk of treatment failure. So let's tackle the first item. Our team I've been using ADC values now for a few years. One advantage is that you can have software that is free that you can download from the internet all over the world to your computer to identify ADC values. This gives access to a wide variety of healthcare providers throughout the world to be able to read and learn how to apply these ADC values to their MRI and their patient care. It's readily available in via parametric or multi-parametric MRI. And of course, you need diffusion with image because the ADC is calculated with a non-exponential decay model formula from the V values from the diffusion with image. We use, of course, the minimum ADC value in the voxel, which is the average ADC for each voxel. But most important is that this technology has to be identified per scanner. So each scanner has a signature for ADC value. So you need to find what your scanner does as far as ADC values. You need to probably identify 10 patients with different ADC values that corresponds to each cancer type, and then use those ADC values in your advantage for future readings. So I want to mention that we were in the Society of Urologic Surgery meeting recently, and our team of students presented at this meeting last month in Strasbourg, France. And I was honored that one of our abstracts won the Best Urology Abstract Award. This meeting is attended by the world experts in robotic surgery, and we, again, were honored to receive this award. This abstract was actually of great interest, and one of the urologists from India expressed how excited he was in possibly using this technology to be able to identify ADC values, not only in prostate cancer, but also in kidney cancer. So this study includes 184 lesions. We did this retrospective study, IRB approved, and we found a linear correlation between ADC values and Gleason scores. Again, we selected the lowest ADC value, the lowest ADC voxel of the ROI, not the average, in order to minimize confusion on the values. Now, I'm going to demonstrate some, these to be videos, but for time constraint, we're going to just show you picture frames. In this particular picture, we have a lesion that is in the posterior peripheral zone, the left side, and corresponds to a minimum of 424 micrometers square per second ADC. These correspond to Gleason 4 plus T, Gleason score also pressure tertiary pattern 5, pre-form introductory features were present. It was a T3B disease. And interesting here that the cipher was intermediate risk. The cipher is a genomic test that allows us to observe different genes that are activated for different kind of prostate cancer. Now, in this second slide, this is demonstrating a ADC value of 374, which is less. And noted that this is at least on 4 plus 3 as well. But the cipher is high risk. So why do I mention this is because at this point we're doing a study correlating the cipher genomics with ADC values. But so far we don't have any conclusive findings. And I think we're gonna need quite a large number of patients to be able to see if we find any correlation. In this third example, we have an ADC value, again, another left peripheral zone posterior lesion with an ADC value of 278 that corresponds to at least on 8 extracapsular extension with a high decipher risk. And lastly, at least on 5 plus 4 equals 9 of T3 disease with a extracapsular extension. This patient actually came to me after 2 different MRI fusion biopsies by 2 different urologists. Now his PSA had increased to 39. And we were very fortunate to identify that the minimum ADC value of 67 was present in the intravesical prostatic median lobe. I performed a transrectal MRI fusion guided biopsy, and we identified this tumor, and the patient had a prostatectomy and showed gross disease extension. Now, I like ADC values, and in my practice, I use MRI-guided robotic-assisted transurethral ultrasound ablation of the prostate for treatment of prostate cancer. I do whole gland, and I like this technology because the MRI scanner demonstrates the anatomy by the millimeter, so I can see what I treat and treat what I see. And I'm able to actually incorporate any type of margin. So if I see that there is extension of disease, I can actually easily extend the treatment margin during the planning. The planning has also benefited from AI software, which with a nice coefficient of over 0.9. This has helped me in my improve my operating room time. I also want to mention that the 5-year study demonstrates that this technology is comparable to curing prostate cancer as robotic prostatectomy. However, the rates of incontinence and erectile dysfunction are minimal in this patient cohort after this procedure compared to radical prostatectomy. Now, our second goal is to identify prostates without cancer. And in this study, we use 50 patients, again, retrospective study, IRB approved. And we carefully looked at every single MRI slice and each compartment of each slice and selected the lowest ADC values, calculated mean and median, which did not differ. And we found that in the peripheral zone, a value over 900, and in the transitional zone, value of 700 or more correlated with no cancer. In addition, these patients were found to have an average of around 70 years of age with a PSA density of 0.06, normal testosterone levels around 437, and normal estrogen levels. This is important because I took part of a study that is published, and it demonstrates a relationship between low testosterone levels and risk of high-risk prostate cancer. Our third goal is to identify extracapsular extension, and this is extremely important because it has been demonstrated that what predicts treatment failure or biochemical recurrence is extracapsular extension. And in this study, there was many variables used and different multiple AI algorithms, and all of them came back with the same thing. Extracapsular extension was what predicted failure or biochemical recurrence. So also MRIs can be used to predict extracapsular extension with very complex AI algorithms. My colleagues, Dr. Saitali and Khosravi, used this algorithm and were able to detect with 0.88 the presence of extracapsular extension. This is extremely important because it can affect how you plan for radiation therapy. If you are aware of where the cancer is located, extracapsular extension, maybe optimize the dosage on that area. The same with extending margins, robotic assisted laparoscopic radical prostatectomy, and of course, I extend the margins as I do ablative technology treatments with my patients. Now, will identifying these and treating them accordingly improve long-term survival? Only time's gonna say. In conclusion, I want to thank you for your attention, and that yes, we find that PIRA's interpretation is variable. The various AI software have proven to improve accuracy, and that ADC values can potentially help the urologist guide them finding a correlation between Gleason score, but it's device dependent. And we need to continue developing this technology because it's helping us improve diagnosis, avoid unnecessary prostate biopsies, and identify extracapsular extension to maximize curative treatment. Thank you very much.